Thank you. Malignant cells essentially grow and proliferate in the human body by creating defense mechanisms or pathways that survive in the body. And amongst these include evasion of growth suppressors, sustained proliferative signaling, pro-angiogenic pathways, etc. And for each of these pathways, more and more we're gaining knowledge on how to therapeutically target these defense mechanisms. And, here are some of the common ways that, we target against these proliferative pathways. But most recently, in, the past decade or so, or even longer than that, there's been a greater appreciation and understanding in the scientific field in terms of the ways that cancer cells evade the immune system. And because of the greater understanding, we've been able to develop a field of immunotherapy where we create agents or different technologies where we can try and sort of reprogram the cancer cells to no longer evade the immune system and for the immune system to recognize and eradicate the cancer cells. So I'd like to spend a little bit of time just to review just how tumor cells mediate immune dysregulation. There's many other mechanisms, but I'll go through sort of some of the salient and important pathways that we're aware of. So first, it's really important just to understand and review the basics of T cell biology and understanding how T cells get activated. And once you understand this, it's easier to understand how the dysregulation ensues. And in an ideal world, what we would want is for the immune system to recognize the cancer much in the way that it recognizes bacterial or viral pathogens as being foreign invaders in the body. And in order for these foreign invaders to be recognized, one of the prime adaptive mechanisms that we have in terms of the adaptive immune system is the activation of specific cytotoxic-specific T cells and memory cells that specifically recognize the antigen or the invading abnormal peptide that's in the body that should not be there. And so here's just a schema to review T cell activation. So here is an antigen presenting cell, and characteristically dendritic cells are a common antigen presenting cell that we all learned about that are extremely potent antigen presenting cells. And here is a T cell. So antigen presenting cells essentially have MHC complexes 1 and 2 that carry an antigen. So this purple circle is basically a peptide or an antigen, so that could represent a tumor peptide or a bacterial peptide. And what happens is that T cells have a unique T cell receptor that recognizes this peptide or epitope, and there's binding there. But in order to really activate this T cell to want to get rid of the foreign or the invading peptide or antigen, you need something called a co-stimulatory signal. And essentially, here on T cells, there is a CD28 receptor, and which binds to CD8086 ligand. And once you have this T cell receptor MHC complex connection, as well as a co-stimulatory signal, only then can you really get the T cell activation. So this is sort of a very kind of simple way of the general principle, but of course it's never so simple in the human body and in biology. So in addition to these two signals, T cells share many accessory receptors that modulate these signals. And essentially, if you ligate these T cell receptors, then you create an inhibitory signal where the T cell activation is abrogated, and the T cells basically become anergic or don't respond. They don't see the antigen, they don't get activated to get rid of it. And on the contrary, T cells also have activating receptors. So if the activating receptors are ligated, then you get T cell activation. So here you can see that PD1, which is called program death 1 receptor, is an inhibitory accessory receptor on T cells. And when this pathway is ligated, that leads to the abrogation of T cell activation. So so that's sort of the normal way things work. And so how do tumors basically hijack the human body and the immune system to evade recognition. And I often tell my patients when I try to explain this, it's like Harry Potter and the cloak. So tumor has a cloak on and is hiding, and how do we sort of take that cloak off and expose it to the immune system for eradication? So one of the most important things is that tumors characteristically have ineffective antigen presentation. And how does this happen? Tumors downregulate their MHC complexes so that they're less apt to present the tumor antigens appropriately to T cells. Moreover, I describe sort of the normal co-stimulatory pathways in terms of T cells, but there's definitely dysregulation of these pathways where T cells in the tumor microenvironment upregulate these inhibitory receptors such as PD1 or TIM3 or LAG3, which you may have also heard of, which are sort of up and coming. And this leads to essentially abrogation of T cell activation. And another thing that happens is that tumors recruit essentially immunosuppressive cells. So they recruit T regulatory cells, which essentially are the T cells we don't want. They basically are there to not attack, not recognize a foreign antigen. So they surround themselves by these regulatory cells, and that creates a tolerant or anergic environment. And there's also other cells called myeloid-derived suppressor cells, which are immature myeloid cells that essentially gather around in the tumor milieu and also help to foster this immunosuppressive state. And finally, all of these cells in the tumors can release immunosuppressive mediators that really further perpetuate these pathways of hiding from the immune system, essentially. So this schema looks a little complicated, but I'll walk you through it. So essentially what this is the immunogenicity of a tumor, and how are tumors predicted to be either immunogenic, where you would want a tumor to be immunogenic, you would want it to be seen by the immune system, as in blue, why are sometimes tumors more tolerant or hidden from the immune system? And, in terms of tolerance, we talked a little bit about these, just the microenvironment. There are certain cytokines that are more tolerant, like IL-10. We talked about PD1 expression on T cells, surrounding themselves by myeloid suppressor cells, whereas in tumors that are inflamed or sort of primed for the immune system to see them, there are inflammatory mediators such as interferon gamma, which is one of the mediators secreted by activated T cells. And aside from just the tumor microenvironment, though, there are a myriad of other factors, including the genetics of a patient, the age, the microbiome, viral infections, even exposure to sunlight, and if patients are on immune-modifying drugs such as steroids, which are anti-inflammatory, all of these predict whether a tumor cell is going to be more immunogenic or more tolerant. And this is a little bit of an even more complicated picture, but I just want to make a point of, this is basically the life cycle of how a T cell recognizes antigens and then gets into the tumor microenvironment, gets into the tumor and kills the tumor. So the steps include, one, you need the release of cancer cell antigens. So as I previously alluded or talked about, tumor cells have ineffective antigen presentation through the downregulation of MHC complexes. And so, this would be inhibiting this area. You then need sort of an you need cancer antigen to be presented to the T cells appropriately. You need priming and activation of the T cells, which is the two signals that I was talking about. Then you need the T cells, once they get activated, to actually traffic to the tumor. So they have to go to where the tumor is. Then they have to infiltrate into the tumor. So, in terms of thinking of a perfect example of this, pancreatic cancer has a dense sort of kind of fibrotic shell around it. So even if you have all these T cells trying to get there, they can't penetrate inside. And so that's a huge problem, even though they're activated. And finally, once they get in, they have to then definitely recognize the cancer cell when they're in there and then kill the cancer cell. And it's quite complicated. And basically what these inner circles are saying is that each one of these steps is affected by the tumor itself, different therapeutic agents a patient can be on, such as if they're on prednisone, environmental factors, again, the microbiome and host genetics. So it's really complicated to, make this all work perfectly. And certainly there's so many effectors in this entire pathway that can either perpetuate, to get to the killing or stop or halt this process. So I'd like to spend the rest of the talk really honing in on the PD1, PDL1 pathway and just talking about what this pathway is, how we've applied our knowledge to create therapeutic agents that mitigate this pathway or modulate this pathway, and then some, research that's going on to sort of better understand how we can, make use of understanding novel aspects of this pathway to enhance therapeutic efficacy. So what's important to know is sort of how did this even get discovered? So in 1999, the gene for PD1 was initially cloned, and in around just after 2000, there were some experiments preclinically done where they took mice and they knocked out the gene for PD1, and what was observed phenotypically was essentially autoimmune phenomenon. So that basically tells you that PD1 is involved in immune regulation, and if you don't have PD1, the immune system is overactivated, producing a phenotype of autoimmunity. In 2006, there was the first sort of experiment of a pilot clinical trial introducing a therapeutic antibody against PD1 into patients to see if it was safe and assess toxicity. And since that time, there's been a series of phase 2 and 3 randomized trials in many different malignancies, which I'll talk about in a little bit, ultimately leading to the FDA approval of the first anti-PD1 antibody in 2014, and that's for metastatic melanoma. So just to review, what exactly is this pathway, again, in more detail? So in the first slide, first few slides when I discussed the normal pathophysiology or biology of T cell activation, basically here is a tumor cell. So a tumor cell acts like an antigen presenting cell. There are, a myriad of cell surface proteins, which are antigens associated with the tumor. Some can be tumor specific and some can be what we call neoantigens, which are inherently unique to the specific tumor of that patient. And essentially, tumor cells do have MHC class 1 expression, though they often downregulate it. Here is a tumor antigen, and it's binding to a unique T cell receptor on a T cell. And then here is the accessory pathway where tumor cells aberrantly overexpress PDL1, which is a ligand to PD1, and T cells in the microenvironment often aberrantly overexpress PD1, and when you get this binding, again, it leads to an inhibitory signal, which causes what we call T cell exhaustion, which means that there doesn't recognize the tumor, sort of the activity of the T cells is null, and decreased cell killing. And if you essentially block this binding, block this ligation either by blocking PDL1 from binding to PD1 or vice versa, then you can abrogate this basically anergy and re-enhance activation and cytotoxicity. So what is also important to know is where is PD1 and PDL1 normally expressed. So PD1 is normally expressed on lymphocytes, and of course we've talked about T cells and it being a co-stimulatory receptor on T cells. It's also expressed on B cells, monocytes, and natural killer cells, where natural killer cells are part of our innate immunity and are not MHC restricted. PDL1 is present on antigen-presenting cells, also on MDSCs, which I discussed can be found in the tumor microenvironment and foster an immunosuppressive kind of milieu, on endothelial cells, pancreatic islet cells, and epithelial cells. And it's thought to be on sort of these islet cells, et cetera, to protect them from immune-mediated destruction. So then, just to review, the PD1, PDL1 pathway, essentially activation or ligation of this pathway leads to T cell tolerance by abrogating T cell activation. And then the next question is, I mentioned, tumor cells essentially aberrantly express PDL1 or aberrantly overexpress PDL1. How does this happen? Is it just innate? Does it get induced? Sort of why does this happen? And there's two different sort of hypotheses based on preclinical work. One being that inherently a tumor cell has oncogenic pathways that are constitutively activated and lead to PDL1 expression. So just the tumor itself is sort of kind of born, that's the pathway that's sort of innate in the tumor cell. And then the other one is sort of an adaptive immune upregulation of PDL1, which I find more interesting, and actually it's more concerning, because essentially what this is saying is that if you have a lot of inflammation around the tumor, which would be a good thing, we want the tumor to be inflamed because we want inflammation to be there and kill the tumor, that it's kind of like a feedback loop, that inflammation with cytokines such as interferon gamma, which is a cytokine that T cells that are activated secrete, causes pathways in the tumor to then basically transcribe and translate PDL1. So it's almost like, okay, you're trying to kill me, there's a lot of inflammation, I'm going to upregulate so that I can survive this active inflammation. So that's another mechanism by which they aberrantly express PDL1. This is interesting too. So this is sort of, more work has recently shown that the PDL1 pathway creates metabolic derangements that also promote an exhausted phenotype by affecting amino acid metabolism, etc., through the PI3 kinase pathway. And this is essentially this schema, kind of just repeating and reiterating what I said, is when you get ligation of this pathway, you essentially have tumor tolerance. Immune system can't see the tumor. And when this pathway is blocked, you sort of restore an activated effector, T cell effectors and memory cells to recognize and kill tumor and to create a durable memory response for future exposure to tumor. So what I'd like to spend a couple minutes talking about next is what have we learned in terms of checkpoint blockade, which is another way of saying checkpoints are these PD-1 and PD-L1 pathway are also referred to checkpoints in blockade in solid oncology. So this is just to reiterate the PD-1 and PD-L1 ligation. And again, here we see that there has been the development of several anti-PD-1 antibodies, including nivolumab or pembrolizumab, which you may have had patients on or read about clinical trials with these drugs. And there have been a number of anti-PD-L1 antibodies that have been developed, such as durvalumab. And so here is just a schema of, how these medications got FDA approved and sort of the timeline of how long it took for these to go down the pipeline to FDA approval. And I previously mentioned in one of the slides in terms of the discovery of PD-1 that the first pilot study of introducing an anti-PD-1 antibody into patients was in 2006. And since that time, in terms of solid tumors, there has been a series of phase 2 and 3 trials, namely in melanoma. And actually in my fellowship, I was at Beth Israel for my fellowship also, and one of the clinics that we had the opportunity to work in was called our biologics clinic, where basically all of our patients were on these clinical trials and it wasn't FDA approved yet. So it's really kind of neat to have seen the patients on the trials, and some of them had amazing responses, and now it's so the fellows behind me are just like prescribing these drugs, and so we didn't have the ability to prescribe them at that time, but it's sort of amazing just to see in the few years of just my training how the field continues to evolve, and the FDA approvals are kind of going down the pipeline. But essentially, the first FDA approval was in advanced melanoma, which has historically been an extremely difficult condition to gain responses in. Following that was in renal cell cancer, and then following that was, or around the same time, was in lung cancer, and more recently in urothelial cancer and head and neck cancer, there's been FDA approvals. And so these are what are FDA approved, but certainly if you go to PubMed and take a look and do a literature review, you're going to find that people are pretty much jumping on the bandwagon and trying to investigate this in pretty much every cancer, especially in situations where there are not many therapeutic agents that, produce objective clinical responses. So I think, when thinking about all this, one of the questions I ask myself, or people often ask, is how can you predict if somebody's going to respond to these therapeutic agents? And it would kind of intuitively make sense. Well, if I have a tumor that's PDL1 overexpressing at baseline, and I'm going to stain and do immunohistochemistry, and this tumor has PDL1 everywhere, it's got to respond. Well, that's not actually necessarily true. There is not a direct linear correlation with PDL1 expression and response to therapy. And two of kind of predictors of response that have been discovered, or not discovered, but sort of felt to be predictors based on sort of review of our experience in patients and looking back and doing immune correlates, et cetera, is tumors with, I'll start with the bottom one, tumors with dense immune infiltrates. So I'm talking like melanoma and Hodgkin lymphoma. So if you take a biopsy from these patients and we look under the microscope, Hodgkin lymphoma I feel like is the best example. You've got all these immune cells, and it's like cancer cell, immune everywhere, right? So these cancer cells are basically sheltered around these immune cells that are anergic. They're like sitting there and they're not seeing the tumor cells. So if you turn the switch on and then all of a sudden say, wake up, these tumors are surrounded by T cells everywhere, these immune cells everywhere, and all of a sudden they can attack and kind of, eradicate the tumor. And with melanoma also has dense immune infiltrates, and so, that seems to be predictive of those responses, and that's why we see really dramatic responses, especially in those two subsets of cancers. And, it's been shown too that tumors with a lot of mutational burden seem to respond better, and why might that be? So if you have a tumor with high mutation rates, what happens is that you develop a lot more antigens and neoantigens on the tumor surface. And essentially, some of these antigens may be more what we call immunogenic, or basically engage T cells more. And so you basically have a greater repertoire of T cells recognizing all these different antigens. And so if some of these T cells are anergic, and you flip the switch and activate them, you have a greater chance of sort of, some of them being more some of the antigens being more immunogenic, and T cells kind of going in and honing in on the cancer. So there's just more of a chance that one of the T cells is going to recognize that tumor and kind of get rid of it. So that's sort of another, but we're still learning a lot about this, and I don't think we have, as a field, have a good handle on this. So I'm going to move on and talk about a little bit about checkpoint blockade and hematologic malignancies. So I feel a lot of the research always starts in solid onc, and then hematologic malignancies kind of jump on and say, let's check and see, what's going on and if this would be applicable to our patient population. And, as therapies for heme malignancies, especially AML, haven't changed all so much in 30 years. So we still do 7+3, and we still have room for improvement. So there's a lot to kind of improve for kind of what I treat every day. But I think, I've already alluded to this. I think the most impressive data in terms of monotherapy with anti-PD-1 therapy has been in Hodgkin lymphoma, for the very reason of the sort of dense immune infiltrates and the ability to sort of, turn the switch back on and allow the immune infiltrate to sort of eradicate the tumor. And this is, kind of a landmark paper by Ansel and al. And essentially, this work and further studies have led to the FDA approval in the context of relapsed refractory classical Hodgkin disease, which is a very difficult disease to get responses to when people have been down many lines of therapy. And I think what is quite impressive is really, so the top figure essentially shows that all of these patients were relapsed refractory, either A, after a salvage auto, so they had already relapsed, because you want, kind of do an upfront auto, but like a salvage auto in the context of relapse, or they had both an auto and brentuximab, which is an anti-CD30 antibody that is now being actually incorporated in upfront Hodgkin lymphoma, but is more historically been used in the relapse refractory setting, and or some of the patients actually failed both of those. And what's more impressive is the waterfall plot down here, which we never see this in oncology, where essentially this is the percent change in tumor burden, and of the 23 patients, 3 had stable disease, and the rest at least either had a partial or complete response. And really, like, we know in oncology, we never see the, sort of everything kind of going down. So I think the waterfall plot is sort of an example of why people sort of step back and were quite impressed by the efficacy. And again, I'm not touching on durability because, these in general, are not, durable forever, but in terms of at least getting a response and, for some degree of time is sort of impressive in this cohort of patients. So I also wanted to show a case report, which is quite interesting, of using anti-PD1 therapy in Hodgkin lymphoma following allogeneic stem cell transplantation, which is very tricky. And this is something the field really is, this is very experimental, and I think we need to learn a lot more about this because there's dangers to this, which I'll get to later in the talk. But essentially you can see that this patient had significant amount of disease and received 1 month of anti-PD1 therapy, and that's the PET right there, which is a pretty marked response. And, again, this is a case report, so the long-term data on this patient, I don't know, but in terms of an initial response. And the idea after of giving PD1 therapy after allotransplant is the following. So as we know, allotransplant is essentially just getting a donor immune system into yours. So you're just getting somebody else's T cells essentially that will recognize your tumor as foreign. And what happens likely in patients who relapse is there's a lot of reasons kind of biologically what could happen, but one of them could be that the donor T cells become anergic and upregulate PD1. And if you can turn off the PD1, you can restore kind of the T cells' ability to recognize tumor. And so perhaps this is why this worked in this context. You sort of like revived the T cells that became allergic from the donor. And so what really, aside from Hodgkin... Sure.
What about this concept from stem cell collection challenges? If I have a patient that going to the direction of allogeneic transplant...
Yep, and doing PD1 before.
Correct. Is it safe to do it, or you've been hearing some mixed messages?
I know. I think people do it with great caution. I don't think, to be honest, we know enough. I can give you an anecdote just of a patient, because when you combine immune therapies, we just don't know enough in terms of like the timing and the characteristics of the patient. And I'll give you an example of a story where this went really bad. But for example, I'll just give you an anecdote right now of a patient that we're taking care of on the floor who had we have a CAR T cell trial at Beth Israel right now. So a patient with relapsed refractory lymphoma received CAR T cells and had a response for a little bit and then just exploded. The disease just exploded, just really bad lymphoma. And he went to, actually got PD1 therapy, anti-PD1 after, and the idea behind that is basically same as the allotransplant. If the T cells get anergic or upregulate PD1, so basically the CAR T cells presumably just, upregulated PD1, and so he got the PD1 antibody and essentially has like terrible cytokine release syndrome, was in the ICU, really bad. So I think that, in the context of allotransplant and 2 different immunotherapies, I think that we just don't know enough, and there really needs to be sort of more, I think, to be honest, more dedicated trials, because I think the only way we're going to objectively understand it is if we actually put people in a trial and come up with kind of a way to assess what happens when we do that. But I think people are a little bit wary of it. In terms of, aside from Hodgkin lymphoma, has PD-1 therapy or anti-PD-1 or PDL1 therapy been trialed in other hematologic malignancies? And the answer is yes. So this is a pilot phase 1b study that looked at about 80 patients with relapsed refractory heme malignancies, including follicular lymphoma, diffuse large B-cell lymphoma, CTCL, cutaneous T-cell lymphoma, and multiple myeloma. And it's a phase 1 study, so you can't really say too much on efficacy, right? But you can, there were hints that, there might be some activity in B-cell lymphomas, but in the cohort of multiple myeloma patients, which there were only 20 in here, and no patient had objective responses, and there was a subset of patients who had stable disease for about 14 weeks. So again, it didn't seem like with myeloma, again, you can't say too much with the phase 1b trial, but it wasn't looking, like there was a great signal, at least in this small cohort of patients. More recently, in Blood, this was published where this is in primary mediastinal B-cell lymphoma, and I'm sure you all have seen primary mediastinal B-cell lymphoma, which is generally a B-cell lymphoma that afflicts patients in their 20s or 30s and is actually extremely sensitive to a chemotherapeutic combination dose-adjusted R-EPOCH, where patients who get treated with that have a great chance of durable lifelong remission. However, the bad part of this disease is if they don't respond or they relapse, it's extremely difficult to get back into control. And so this is some data, again, showing in a very small cohort of patients. So again, you can't make too much presumption from these studies, but it looks like, out of the 16 patients that, received this in the relapse refractory setting, there at least was some indication or sign of potential efficacy. And obviously this will have to be looked at in a greater number of patients. But again, this is a disease where in the relapse refractory setting, it's extremely hard to achieve objective responses in these patients. So I think, we're seeing more and more of this. People are using more of this, and then you wonder, well, it sounds pretty good, right? But there's a lot of toxicities, and again, it's non-specific, right? So when you're activating the immune system, you're not just activating towards the tumor, you're activating your whole immune system, and so it's really not a clean drug. It sort of has effects for the rest of it. It's not targeted specifically to the tumor. So again, these drugs basically rev up your immune system. So in patients who have underlying autoimmune conditions, really they're not or shouldn't be candidates for these drugs. So can create severe exacerbations of their autoimmune diseases. In patients who, certainly on clinical trials, basically exclusion criteria is autoimmune diseases, but the data that we get from clinical trials in patients who don't have any known or had no previously known autoimmune condition, you can get very, very severe manifestations, including pneumonitis that can be life-threatening or fatal, severe colitis where patients are in the hospital and really, really, really ill from this, adrenal insufficiency, so on and so forth. And sometimes it's so severe that we actually have to treat with steroids and actually immunosuppressive agents. So you kind of treat it like it's Crohn's disease in the very extreme cases. And so this is the other, I showed you one case report of using PD-1 therapy following allogeneic stem cell transplant with a remarkable response. And of course, we don't have the durability and how long that lasted because it's a case report. But there are also reported cases of fatalities. And this is due to basically causing severe graft versus host disease. So in one patient with Hodgkin lymphoma here, this patient had relapsed refractory Hodgkin lymphoma, had an allo, and even relapsed after the allo. And one difference in this case is that this patient actually had a history of graft versus host disease. So just to review, what is graft versus host disease? So when you have an allogeneic stem cell transplant, you have a donor immune system come into your body, and we would hope that that donor immune system is specific for the tumor and only recognizing the tumor, but we all know that the biggest downfall of allogeneic stem cell transplant, which is essentially the first immunotherapy of all time. That's like the premier example of immunotherapy, is that it's nonspecific. And unfortunately, these donor T cells will see the other antigens in the human body as foreign and can cause severe reaction in the skin or gut or liver and so on and so forth. And so this patient had a history of GVHD, not active at the time of PD-1 administration, and then unfortunately developed very fatal GVHD. And this is basically just saying that we just don't know kind of what we're doing enough to basically pick the right people to try this on, and you have to be really, really careful. And then, you may ask, well, okay, these toxicities sound really scary, and what's the incidence? What can we expect if we treat patients with these therapies? How often do you see these autoimmune manifestations? And I think, certainly we have the biggest cohort of patients in clinical trials of having received anti-PD-1 therapy in melanoma. And here is, basically, some of these are not just PD-1 antibodies, but all focused on the anti-PD-1. But for example, here an anti-PD-1 antibody in 210 patients, 12% of those patients had grade 3 or 4 autoimmune manifestations, which are clinically significant. And here, what's, nivolumab, which is an anti-PD-1 plus ipilimumab. So ipilimumab is an anti-CTLA-4 antibody that also has been used in the context of metastatic melanoma. And in one trial, an early phase 1 trial, looking at that combination, they did, observe 50% of patients had grade 3 or 4 toxicity. So, and I'll talk about this in a little bit, that there is a lot of work in the field trying to combine different immunotherapies, but we have to be kind of cautious in dosage, timing, etc., because of the, kind of compounding the toxicities of overactivating the immune system. Brings me to my next slide. So essentially, monotherapy with anti-PD-1 or PDL1, really the success stories are more in, Hodgkin lymphoma, melanoma, etc., lung cancer and those settings. It's certainly FDA approved, but, in terms of progression-free survival and overall survival in the context of those diseases, it's pretty impressive, but it's not durable for years, so people will ultimately sort of become resistant to these therapies. And so the question is, can we do better? Can we potentially combine these therapies with other therapies in a hopefully not toxic way to try and gain additional control on the tumor? And so this slide essentially looks at current day, what kinds of immunotherapies are out there, and do they affect T or B cell immunity? Do they affect more of the innate immune system, which are like natural killer cells? So there's some natural killer cell therapies. Even for AML, there's a clinical trial where you infuse natural killer cells and see if that can gain control of the disease. But a lot of these we've heard about, such as CAR T cells or chimeric antigen receptor T cells, which in ALL obviously is the premier example, and right now with diffuse large B-cell lymphoma, there's sort of breakthrough designation approval that's coming up, that is actively happening, and bispecific antibodies, vaccines, so on and so forth. So there's lots of different kind of immunotherapies that can be considered to potentially rationally combine with checkpoint blockade to enhance responses. And so previously I showed that in a small pilot study of myeloma patients, we really didn't appreciate a big signal of monotherapy with anti-PD-1, but this was recently published in Blood, and there's a lot. So now there are, if you go to clinicaltrials.gov and try and look up trials in myeloma that have to do with PD-1 therapies, you're going to see that they're pretty much all combinatorial. And here in patients who had relapsed refractory multiple multiple myeloma. They received an anti-PD-1 therapy with a novel or second generation IMiD, or really third generation IMiD, pomalidomide, and low-dose dexamethasone. And in this cohort, the progression-free survival was on average over a year and a half. And so, again, with myeloma, overall survival is a little bit of a difficult to say in studies where you're only looking at like a 2-year time point, because patients with myeloma, historically, on average can live 5, 6, 7 years. So it's hard to kind of make an overall survival. I think that's always a criticism with sort of myeloma work, but in terms of progression-free survival, having about a year and a half is close to equivalent to like an auto stem cell transplant, where the average is about 2 years. Certain people can get more or less depending on the risk profile of the myeloma. And so the next thing that I wanted to talk to you guys about is some of the work that we're doing at Beth Israel in terms of a cancer vaccine in the context of multiple myeloma and leukemia, and how we're trying to potentially incorporate, and how we actually are incorporating investigationally, checkpoint blockade in the context of this vaccine. So we have a dendritic cell-based vaccine, and I'll talk a little bit about what this is so that it makes more sense and the rationale for potential combinatorial therapy makes sense. Is that why use a dendritic cell? So we already sort of discussed this earlier in the talk, is that dendritic cells are the most potent antigen-presenting cells and have a lot of expression of MHC 1 and 2 complexes, which are needed to present antigen in order to activate CD8 cytotoxic or effector T cells, as well as CD4 memory T cells. And they attract other immune effector cells. So they're sort of a nice cell that you would want around to use it in a vaccine model. And so this is essentially showing that dendritic cells have high expression of MHC 1 and 2 and co-stimulatory ligands, and in contrast, tumor cells are quite anergic. They lack co-stimulatory molecules, upregulate PDL1, downregulate MHC, so they're relatively anergic. But what do tumor cells have that we want? What's the good thing about tumor cells? Tumor cells have a myriad of antigens and neoantigens specific to the tumor cell. But they have mechanisms where these antigens are not presented. So is there a way that we could somehow just present the antigens? Well, the idea behind this vaccine is to take autologous dendritic cells, so patients' own dendritic cells, and I'll explain in a second how we do this and how we get these. But essentially, dendritic cells are great antigen-presenting cells, have MHC 1 and 2. You take a patient's tumor cell, and with polyethylene glycol, you kind of shake it in a tube, and they fuse. And you get this hybridoma of a cell that is a dendritic cell bound to a tumor cell. And now what you have is a tumor cell with antigen presenting capabilities, and you're able to now present the tumor antigens to the immune system and effectively, we have we'll talk about the clinical trials, but and then presumably effectively, elicit an immune response towards the tumor. So that's kind of the premise why we would do this, or why this was thought about. And this is work done in David Avigan's lab, and I work in his lab too. And so this is basically an example under the microscope of what these fusions look like. So this in blue, so dendritic cells are pretty big. So that's a dendritic cell, and we stain it for CD86, which is a marker of dendritic cells. And then this is right here, a myeloma cell that was stained for CD38. And so this is not fused right here, but you see right here there's sort of these hybrid cells, and so that's basically an example of a fusion cell or a hybridoma. So this vaccine model has been both tested in multiple myeloma and in acute myeloid leukemia, and we currently have 2 phase 2 trials, one in leukemia and one in multiple myeloma, trying to assess efficacy of this, because the phase 1 trials show that these were safe and had signs of efficacy, but we obviously need larger numbers and to kind of statistically show if they do actually produce clinical responses. So how do we do this? So I'll give you an example of a leukemia patient. So let's say a leukemia patient comes to the hospital and we have a trial with a vaccine. What we do is, if they consent to the trial or are interested in participating in the trial after we discuss with them, we do what's called a tumor collection. So how do we do that? Well, with leukemia, if patients present with a very high peripheral blast count, we can do leukapheresis and collect tumor cells in that way. If it's a leukemia where the counts are not that high, but the bone marrow is packed with leukemia cells, we can do a tumor collection with a bone marrow aspirate, where we collect about 30 cc's of aspirate. And then what do? We isolate the tumor cells from either the leukapheresis product or the bone marrow aspirate, and we cryopreserve the tumors for a possible future date. Then patients, so I'm basically explaining our phase 1 trial, so I'll show you kind of the results on the next slide. So in this phase 1 trial, patients basically had their tumor collected in the way that I just explained. They then underwent standard of care to you induction chemotherapy. So if you thought 7+3 was the right thing to do, you do 7+3. If you think decitabine is the right thing to do, you do that. If they have low risk AML and you do 7+3 with HiDAC, whatever you think is, take care of your patient, that's what you do. And if patients were not transplant eligible, so a lot of people get enrolled in the trial, but then end up going to transplant, so they won't get the vaccine. So this is only for patients who achieve a chemotherapy-induced response and are not transplant eligible. Then those patients were administered a series of vaccinations every 4 weeks, 3 vaccinations with GM-CSF. So that stimulates dendritic cells. It's a cytokine that basically just stimulates dendritic cells. And that's what we did. And then we observed these patients to see if they progressed and if they survived. And this is the data that we have in our cohort of 17 patients. The median age of these patients was 63 years old. As I mentioned, they had a personalized tumor vaccine that's created and received 3 vaccines every 4 weeks, and median follow-up was 57 months, and at this median follow-up, 12 out of the 17 patients were still alive, which is, compared to historical control with patients with an average age of 63, it's like 10-20%. So again, this is a very small study, and other questions you may ask is, okay, well, were they all low risk? Or you could also say, hey, they got into a chemotherapy-induced remission. Aren't you selecting people who get into a chemotherapy-induced remission? Well, perhaps you are, so that's why we need a larger number. But 11 of the patients had intermediate or high risk AML, and 8% had favorable risk. So again, these are,
What are the reasons for those patients are in CR?
Yep, in CR.
And why they are not going to the transplant?
Yeah, so either they don't have an eligible donor or they have another medical comorbidity. There's something that precluded transplant. So transplant is the standard of care, so certainly they would go to transplant if we had. So sometimes they just don't have a donor, or there's not even a cord, or or something comes up and they have a comorbidity or heart failure or something. That
patient has to be in CR.
Has to.
That's the only way.
Yes, so correct. So we haven't actually tested this vaccine in the setting of active disease. I have tested it in the lab in mice, and I'll talk about that in a second in terms of what we saw in sort of preclinical. It's never been given in humans with active disease yet, but that's something that we will likely do. And so this is essentially a little bit of a busy slide, but I'll walk you through it. It's basically saying that we observed an expansion of leukemia-specific T cells in patients who got the vaccine. So essentially, how do we do this? What we do is that when we collect the tumor with the leftover cells that are not used to make the vaccine, we create tumor lysate. So we take the tumor and do things to the tumor to make all of the antigens spill out, so you have a bag of antigens. And then what we do is, prior to the patient receiving the vaccine, we take their blood, just a blood draw, and we what's called phycol the blood and get out the peripheral blood mononuclear layer and get the T cells. And we co-culture the T cells with the bag, not the bag, but the media that has all the lysate, the tumor antigens, and we see, is there an immune response? Does the person's T cells recognize that leukemia? So, and then we do that prior, to each vaccine to see if the exposure to, or if the vaccination accentuated an anti-leukemia response in terms of T cells. And so what we see here, this is just basically an example of a patient that following, 6 months after the vaccines had an increased interferon gamma release of T cells that were co-cultured with autologous tumor lysate, showing that there is some immune response in terms of immune correlates. And then basically this is showing the white is baseline CD8 interferon gamma response, which is a marker of the T cell activation, and this is a peak interferon gamma after vaccination, and you can see that there definitely is signal in almost every patient that they had enhanced interferon gamma leukemia-specific immunity during this trial.
So it's circulating tumor cells initially.
Yep.
You have some strict criteria on this. It has to be a high volume to make this dendritic cell.
Oh, to make the vaccine, you mean?
Yes, for untreated patients. So you're looking at the circulating tumor cells.
Yeah. So, great question. So essentially when we do a tumor collection, if someone has a bunch of circulating tumor, we can collect it peripherally, and there's strict criteria about how much circulating tumor needs to be. In the aspirate, there has to be at least 20% tumor cells in the aspirate, or else we will not get enough tumor cells. So just to give you an idea, like let's say we do a tumor collection and we get 80 million cells. You cryopreserve that tumor, and then later on you get I didn't mention how we get the dendritic cells. We basically, when the patient's in remission, we do a leukapheresis and collect their peripheral blood mononuclear cells and basically collect their monocytes. And then in the lab, we take their monocytes and we expose them to GM-CSF and IL-4, and then that creates dendritic cells, and then we mature the dendritic cells with TNF-alpha, and so we create dendritic cells from the patient, and so we fuse them. And when you fuse, we have about an 80% fusion efficacy. So if you take the, like 80 million initial tumor cells and you have, all of the dendritic cells, you're going to expect that maybe 80% of that are going to be good fusion cells to use as the vaccine. And for each dose, you need 5 million fusion cells. So let's say, you collect someone and you get 10 million total tumor cells, they're not going to be able to get the vaccine. And in order to kind of be eligible to even get the first vaccine, there has to be at least enough cells for 2 vaccines. The minimum that a patient can get is 2 vaccines to make them evaluable in the trial.
It also correlates with CRA too, this circulating tumor cells from.
That's actually a really good question. Does the disease burden specifically aside from the risk? Yeah. No, I don't think we actually specifically looked at that. What is really interesting is that patients who get the vaccine, almost every patient gets kind of a red thing right there, right, when you get a shot. And what we did is we actually biopsied the site of inflammation of the patients, and what we saw, instead of seeing tumor or et cetera, we saw a dense infiltrate of immune cells and dendritic cells at the site of the vaccine, which is quite interesting. So currently, of course, this is all phase 1 data. This is 17 patients. You can't really say this is efficacious, right? It's an early phase study, but currently we have a randomized clinical trial accruing patients to 3 arms. One is getting just standard of care, and so again, it's the same principle. Patients in this study, it's over 55, but it's patients who achieve a chemotherapy-induced remission and are not eligible for transplant. So we enroll a lot of patients knowing that many of them go to transplant. And essentially there are 3 arms. one arm is standard of care, so what you would do as standard of care, give them more chemotherapy, decitabine, whatever you think is what you would do. The second arm would be just the vaccine with GM-CSF alone, which is similar to the first trial. And the third arm is giving vaccine and GM-CSF with an anti-PD-1 antibody to assess if, part of the reason perhaps not everybody responded is that perhaps their T cells were anergic, and if you could, combine the vaccine with anti-PD-1, perhaps you could enhance the response. And so time will tell what this will show, and we're accruing 105 patients, and right now it's open at BI, and it will be open at the other two Harvard hospitals, MGH and the Dana-Farber for right now. So we've also trialed this vaccine in multiple myeloma, and just checking the time. Am I running out of? I don't know what time it is.
Well, it's 1 o'clock.
Oh, it's 1 o'clock. Okay, I'll go through the rest really quick then. So essentially, the punchline in myeloma is similar things. We use this in the setting after auto stem cell transplant, sort of as maintenance therapy. So right now, as you guys know, Revlimid just got FDA approved as maintenance therapy following autologous stem cell transplantation for multiple myeloma patients. And so this is sort of looking at if we use a vaccine after auto, can we sort of enhance progression-free survival in multiple myeloma patients, given the fact that multiple myeloma is not a curative malignancy. And we did see in small cohorts of patients kind of similar, some basically clinical responses, and also sort of the same similar data where we saw myeloma-specific immunity when doing the same thing in co-culturing with the lysate of myeloma cells. And we also did another trial looking at the fusion vaccine in the context of post-auto transplant with a PD-1 inhibitor. And again, in a small number of patients, there seemed to be a signal of at least immune activation and responses. So currently, we're planning a phase 2 trial using this vaccine with an anti-PD-1 antibody as well as lenalidomide, which I won't go into the details, but IMiDs have many immunomodulatory capabilities. So the premise is to try and kind of combine a couple of immunomodulatory agents together in the setting of active disease. So this would be in relapsed refractory patients and seeing, if that actually is helpful in the context of active disease. And right now, to aside without PD-1, what we have is a national randomized trial involving several centers, including Sloan Kettering and MD Anderson, et cetera, where we brought them to Beth Israel and taught them how to make the vaccines, and they all have stem cell facilities in their each hospital, and basically make the vaccine. And we're looking at a national randomized trial of the utility of this vaccine in the post-transplant period to see if it's helpful and improves outcomes. And then I don't think I have time for this, but I'll just end there, or unless you guys want me to go through this really quick. But we have some preclinical data looking at hypomethylating agents, and what we've seen is that hypomethylating agents in a murine AML immunocompetent AML model show some effect on decreasing PD-1 expression in T cells. So this is some of the work I did during fellowship. And when combining a hypomethylating agent with this vaccine in mice with active AML, we saw a synergistic effect, but not a synergistic effect in terms of decreasing PD-1 expression further, but we did see enhanced leukemia-specific immunity, which is what this is showing, and there was a very modest improvement in survival as compared to vaccine alone or a hypomethylating agent alone. And this is just other work in our lab looking at a common oncogene that's present in solid and hematologic malignancies called MUC1, which is an aberrant protein that's expressed in heme malignancies. And basically, we showed that this oncogene is responsible in part for PDL1 expression through the upregulation of microRNAs, which microRNAs function in post-transcriptional modification of genes. And so we also currently have a trial actually looking at a MUC1 inhibitor, which blocks this oncogene with a hypomethylating agent. And actually, hopefully, our group will present this at ASH, but in our subset of patients with relapsed refractory AML, we see some some signs of response in that. And I'll stop there. But thank you very much for your attention. Thanks.
I got two questions.
Yeah, sure.
So I'm a radiation oncologist.
Yeah,
so this
yeah,
is great for me.
Yeah.
But who came up with the idea of taking dendritic cells,
Yes.
tumor cells, and just
So
no. So
shaking it up in polyethylene glycol? Yeah, I mean, so Don Keefe, who I don't know if he is one of the investigators at the Dana-Farber, and he was the mentor of my mentors, David Abigan, and I don't know exactly the total history behind it, but I know it was his, like, he conceived sort of that idea, and I should know the history better, but I don't know how they figured out that. It really is because I make these vaccines and put them in mice. You literally add in polyethylene glycol drop by drop and like tap the cells, and they